Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
I hope that this talk will generate a lot of discussion. I will bring up some topics that don't have very clear answers, and that is on purpose because I would like to see how different people are doing things and really learn from each other. I am currently funded by the National Institute of Health and the Agency for Healthcare Research and Quality. So this is the disclaimer that's part of the ECHO program. I want to start by first talking about the Frascati criteria and how we kind of originally thought about HAND or HIV-associated neurocognitive disorders. So this criteria was developed to really have a unification of classification across research. And it was developed as part of the multicenter AIDS cohort study and then also part of Charter. And so these large cohorts really tried to help us get a better understanding of the prevalence of HIV-associated neurocognitive disorders in individuals living with virally suppressed HIV, and found that about 47%, so somewhere between 40 to 50% of individuals meet criteria according to this criteria for having HIV-associated neurocognitive disorders. These fall into three different categories: asymptomatic neurocognitive impairment, which is one standard deviation below the mean in two or more cognitive domains, but without any evidence of this affecting daily function. Minor neurocognitive disorder, which is the same cognitive classification, but evidence of impairment on daily activities. And then the most severe form, which is HIV-associated dementia, which is two standard deviations below the mean in two or more cognitive domains affecting daily activity. I share this to say that this is really not what I would use clinically. And there are some important caveats to this. If you diagnose someone with asymptomatic neurocognitive impairment, that could create a lot of stigma. It's not really clear what the implications of that are. And so over time, we are really moving away from this classification. And the goal of this talk is really to generate discussion on how do we actually apply some of the tools that we have into the clinical space to help primary care providers triage cognitive concerns. What we do know is that HIV enters the CNS space early in infection within the first week. We also know that there is evidence that those who were diagnosed with AIDS-defining illnesses prior to starting ART have more significant risk for cognitive impairment and lower cognitive reserve. We also, really are looking, particularly in the Charter study, looking at the overlap between HIV and some of the lower cognitive reserve that occurs as a process of aging. We think that some of the injury related to HIV is related to chronic neuroinflammation. We know that antiretroviral therapies don't penetrate the blood-brain barrier as readily, and that can lead to a setup of chronic and persistent HIV infection in the CNS space. And then I'm going to kind of move over to the right side of the screen. We also know that there's a lot of things that affect brain health, right? Lifestyle factors, substance use, history of trauma, mental health and stigma, and comorbidities. And we are really just starting to learn about the implications of all of these things on cognitive health in persons with HIV. So we're going to talk through kind of how we incorporate all of this knowledge into something that we could use in clinic. But first, let's talk about some of the controversies, right? We don't really have a very clear definition of cognitive impairment, and there are a lot of different criteria that are out there that are really trying to parse out these on a research standpoint. But I would share that cognitive impairment at least in the clinic, I define very subjectively. So, does it impact activities of daily living? And if it is impactful, then it is clinically significant. And so, I would try to kind of steer away from this classification of cognitive impairment and more really focus on how it is affecting the patient. The other controversy is who to screen, right? Do we screen everybody or do we wait until symptoms present in clinic? And if someone has symptoms and they're screened and they come back normal, when should we repeat the screening? And we'll talk a lot at the end of this talk about the reliability of screening tools, particularly for individuals living with HIV. And the important kind of thought process in screening for cognitive concerns related to HIV is it actually in fact related to HIV? Or is there some overlap of mental health symptoms, substance use? Also, importantly, cultural considerations. So, a lot of cultures define symptomatology related to cognition differently and may underreport these things. Or is it related to social determinants of brain health? So, these are just some kind of things to think through when a patient presents with cognitive symptoms. For example, they say, Doc, I'm having trouble remembering to take my medications every day. These symptoms should be the focus of the clinical history, but they are oftentimes subjective. And so we use other tools, right, to help us ascertain what is actually going on. We'll want to emphasize too that there can be a cultural bias against reporting. So sometimes it's very important to be proactive and to pick up on subtle things. Like if you notice that a patient doesn't come in for a refill, right? To really kind of ask about if there are cognitive symptoms going on. There can be limited insight into these processes, particularly for older adults. And so if you notice something, it's important to ask again. And even though the patient is a primary historian, sometimes observer accounts are equally important. And so this could be a roommate, this could be a case manager, getting their input on what has been happening over the last few months will be really important in ascertaining if there are cognitive concerns. As part of the clinical history for cognitive symptoms, we should ask about activities of daily living, but this is always in context, right? So we could ask, do you remember to do laundry? But if someone has never done their own laundry, right, that's very limited utility to that answer. So first you want to ask, what kind of things have you been managing on a regular basis and how has it changed rather than kind of a structured questionnaire. And then the important thing to look into is stressors, changes in mental health, and changes in medical history or medication, because these can oftentimes overlap with cognitive changes. And in our own clinic, we sometimes see individuals who have had changes in their general medical health and changes in their medication that present to us with cognitive concerns. And we actually change their medications and they feel a lot. So then we'll go into mass screening, right? And this has actually been a debate in the neuro-HIV literature for quite some time. And this is with regards to whether or not clinics themselves should implement screening tools for every single patient that comes through their door. The individuals that have been for mass screening have discussed that there's oftentimes limited insight. And so sometimes it'll be tough to pick up especially subtle cognitive changes, and that early recognition can provide better guidance for the caregivers of our patients and also help the patients themselves adjust to this new diagnosis. The case against is that even if you screen positive, that doesn't necessarily mean that you're cognitively impaired. And so we worry about the anxiety that this creates, particularly if we use tools that have limited specificity, right, but high sensitivity. So we capture a lot of people that screen positive. does this create stigma, or does this create kind of like this reinforcing narrative that, my brain is not healthy? There's also, unfortunately, a lack of interventions, right? Because we could go forward with cognitive testing, we could identify that a person is significantly cognitively impaired, but we cannot reverse that. We can modify the environment to assist the person, but there's no medication for this. And then importantly, especially for clinics that are under-resourced, this is a huge clinical burden to screen everybody that comes to clinic. So now we'll jump into screening tools that are available. There's this paper that I reference here, which is the selection of cognitive impairment screening tools for longitudinal implementation, and that's where this data is coming from if you're interested in reading the paper. There are many, many different screening tools that are out there. Some are free, some are, cost some money as a one-time fee to access. Some are tablet-based, some are paper pencil. But overall, Brace and Cogstate are tablet-based and they're fee-based. Cogstate is actually available now. Brace is currently being developed. And the International HIV Dementia Scale, MoCA, and MMSC are free, and they are paper pencil based. Of these three have the highest sensitivity in persons with HIV, and MoCA and MMSC, which are actually tests that we use regularly, particularly the MoCA, have much lower sensitivities in persons with HIV. This has actually been shown to be related to cultural considerations for the MoCA, and individuals that are not primarily US based actually have lower reported average scores that could classify them as impaired when they're not in fact impaired. Brace, again, is under development, and here's information about the screening technique that's in Brace and the specific battery, if anyone is interested, but it has really high specificity. Leah Rubin is developing it at Johns Hopkins. And I would share that, MoCA and MMSC have lower specificity, particularly in HIV, but the International HIV Dementia Scale has the lowest specificity. I share this just to emphasize that some of these things are pretty easy to implement relatively, but they always come with this caveat of whether we are over-diagnosing cognitive concerns with these tools. I'm going to share that we use the MoCA mostly because we're very familiar with the MoCA across many neurology clinics, but it has not been the most useful tool in Madison Clinic for screening for cognitive impairment. And really what we do is we actually move forward with cognitive testing if there are significant concerns clinically based on history. I'll also share here the International HIV Dementia Scale. So one thing that I like about this is that, it does have really high sensitivity. One of the reasons why it has high sensitivity is that it can be implemented across multiple languages if you have an interpreter, and it is pretty easy to implement within the setting of a clinic because it only has 4 tests. And so if anyone is very interested in potentially implementing a cognitive screening tool, this would be the one that I would recommend. I think for the sake of time, we'll move on, but we can go back to this if there are questions. The other special considerations as far as implementing cognitive screening is that you really need to have quiet space and kind of this unhurried, at least feel, which doesn't always come about in clinic, in order to maximize the score for the person taking the test. Also, some of these are tablet-based, and so that would be something to look into as far as your individual clinics. And even if you use a paper and pencil one, you want to make sure that you're able to upload it into the electronic healthcare record. There can be variations across time And so sometimes in the neurology clinic, we retest people, and it'll be important to see how that changes over time. And so, broadly speaking, the questions for your clinic and your patient population is what's the most accurate for my patient population? What can be implemented that could be culturally accessible and language accessible for my clinic? What meets the HIPAA requirements? So some of these tablet-based tools may not. What's the best fit for our flow, right? When should we screen? Should we screen everybody or should we screen anyone with cognitive concerns? And what tools and resources can we afford? I'd like to share too that as part of the AAN Advocacy and Health Equity Committee, we are trying to make cognitive screening a reimbursable procedure. And so hopefully that will incentivize people to use it and also offload some of the time burden for trying to implement this in primary care clinics. And that's it for my talk.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.